Greetings, everyone. We would like to welcome you to our live webinar presentation, Fighting COVID-19 with Data, Data Strategies, Resources, and Tools to Predict and Prevent Public Health Risk, co-sponsored by LexisNexis Risk Solutions and Blue Health Intelligence. If you were on an airplane right now, you'd need to listen to some safety instructions before the plane takes off. So buckle up, and please pay attention to these brief items of note before our webinar takes off today. During the webinar, all attendee lines will be muted. To ask speakers a question, on the left-hand corner of your screen you'll see a blue Ask a Question box. Simply type in your question and press Send. If you need any assistance during this webinar, please contact our Health Web Summit office at 209-577-4888. LexisNexis Risk Solutions will discuss how the abundance of demand for healthcare access, mixed with a finite number of care resources, has highlighted the need for insights in the most vulnerable of populations. Social determinants of health data, along with provider and claims intelligence, can help healthcare organizations sharpen their focus as they combat the virus's impact, helping to identify those communities at risk for poor health outcomes and/or those most in need of critical care resources. Blue Health Intelligence will share how the combination of deep data, advanced modeling skills, and clinical expertise are producing descriptive, predictive, and prescriptive analytics that can help healthcare leaders better address the pandemic by combining AI and clinical informatics to predict, identify, and cluster the most at-risk member cohorts and prescribe more targeted interventions, designing peer-reviewed studies to assess the economic, social, and public health implications of recent COVID-19 policies and actions, and using their Wizen solution to help health plans, employers, and brokers explore account-level population risks for COVID-19. Richard Grafe is the Director of Market Planning and Innovation overseeing LexisNexis Risk Solutions Healthcare Claims Analytics Suite. In this role, he acts as part futurist, part visionary, and as a strategic leader that directs the overall market, product vision, and sales strategies as it services healthcare and government nationwide. A passionate advocate for the benefits of sharing data, he has led multiple contributory initiatives and defined data sharing frameworks for projects such as the National Accuracy Clearinghouse. Mary Henderson leads the product development and account management teams at Blue Health Intelligence. Mary has more than 30 years of experience in healthcare reporting and analytics. Prior to joining BHI, Mary served as the Senior Vice President at the American Medical Association's Health Solutions Business Unit. Prior to the AMA, she was President of Health Data and Management Solutions, where her team successfully launched an account-focused analytics platform that was successfully adopted by more than 20 large regional health plans and numerous national employers. Throughout her career, Mary is focused on designing and implementing business intelligence products for a variety of healthcare reporting and analytic needs. So, without further ado, our speakers are now ready to begin.
Hello, this is Rick Grafe with LexisNexis. I'm excited to be joining you all today to give you a little bit of an overview of our COVID-19 Data Resource Center. We have a fairly robust agenda today. I'll be one of two speakers joining you, and I'm sure you saw that as part of your overview. So to begin with, let's talk a little bit about some of the agenda and content we'd like to have an opportunity to discuss with you all. So first, we're going to talk a little bit about the LexisNexis COVID-19 Data Resource Center. We'll get into kind of a deep dive on some of the different data sets and use cases that are available and that this was brought to bear within the market for. We'll talk about some of the key questions that resource centers seek to answer and address within the market. And we'll take some time to also talk through some of the different telehealth insights that have kind of come to bear as a result of trying to address some of those key questions. I hope to take you into a little bit of a live demo and have a Q&A opportunity before passing along to the next presenter. If you do have questions throughout the course of this, please take your time and answer those into the chat question feature. We'll make a point to address those kind of throughout the presentation as well as towards the end of our respective sessions. So to begin with, I'd like to start by giving you a little bit of background on LexisNexis. I've been working with the company for about 10 years. And part of our mission broadly within the healthcare industry is to help the U.S. healthcare system operate much more efficiently and really work to create healthier communities. At LexisNexis, we do this by combining our unique data and industry data in order to provide actionable insights with our customers. And really, that gets integrated into a number of different workflows, those insights enabling them to make better healthcare decisions. As we're all feeling the impacts of the current pandemic from COVID-19, the Lexis team has been working to expand the availability of our data assets as part of a project to provide insights across the industries to stakeholders who need them most. In recent days, we've all seen how the population across the globe has been impacted, and that the pandemic has characteristics that distinguish it really from any other that we've seen within any modern time. This has been from high mortality for elderly populations, looking at those that have one or more different chronic comorbidities or conditions. We've seen that it's highly infectious with a much longer incubation period, causing a significant spread from unsuspecting or asymptomatic individuals. And we've seen that there's a very high demand for and really shortage of critical supporting equipment, things like ventilators, respirators, dialysis, ICU level care. We've seen all of these things as well as critical care professionals that are skilled in their different respective areas. LexisNexis, tied to this mission, has really been working to support the U.S. response by creating this COVID-19 Data Resource Center. As I mentioned, it's within our mission to help build out healthier communities, and there's no more important time for us to be able to offer our resources to the market to do so. As we talk through our Data Resource Center today, I want to focus on some of the areas where we're bringing and combining our unique data assets with those of other industry stakeholders. And you'll see through the Resource Center kind of an interactive visualization that can help provide insights on at-risk populations and care capacity risks. We envision this, and I've heard feedback from folks that are using this in the public health capacity, health researchers, folks that are looking to allocate resources to counties and populations that really need them the most. So you'll see here kind of a preview of the Data Resource Center, and you'll see here that some of the drivers behind this has been working to address the scarcity of resources, leveraging real-time insights as it relates to individuals, practitioners, other diagnoses. I'm going to talk about some of the resources that went into bear for making this a reality. But you'll see within this heat map, it's going to be driven by kind of a percentile ranking. You'll see it in a number of different categories. There'll be a drop-down over on the right. And really, the types of data and analytics that we hope to provide can give really a wealth of insights depending on what folks are looking for. Part of what came to bear for this is our medical claims repository, which can provide a view into at-risk populations due to factors like age and comorbidities. We're also able to shed light on high-risk populations using those de-identified claims to show where there's an indication of risk among those communities nationwide. Another set of kind of unique assets that we've been looking at is really where the transitions in care setting have occurred over the past 2 months. We're kind of in unprecedented times with patient-doctor interactions shifting from face-to-face to more and more steps into the digital age with the adoption of telehealth services. So we'll talk a little bit about telehealth and how we can provide claim insights as to which practitioners have adopted this, what the overall trends are nationwide. And another area I want to spend a moment on, and we'll talk a little bit about, is the ability to leverage those insights to really help provide direction for different assets like medical devices, tests, ventilators, others, to communities that are not only currently affected, but who might be trending towards a higher risk of infection and in the future. So let's take a look at some of the different data attributes that we are actually pulling in for the Data Resource Center. So we're looking at a combination of claims data. So we're looking at submitted 837s as well as remitted 835s. You'll see that there's going to be practitioner information. Some of these are from current, longstanding practitioners that we see, but also emerging NPIs. We're looking at facilities at an office level, at a treatment center level. Again, both current and emerging as more and more testing facilities come to bear, and that's being done in an ever-increasing variety of interactions, from pharmacy settings to those that have been set up in more of a temporary capacity. We've looked at socioeconomic data, so looking at clinically validated attributes, hospital and facility data, including their capacity and capability. And we're starting to expand to look at pharmacy and clinic level data, looking at locations and different capabilities there. So as part of this endeavor, the LexisNexis healthcare business has brought to bear really three major data assets, which are different drivers for parts of our business across the board. One of this is our provider data set, and this covers every healthcare practitioner and organization in the United States. This asset is used to identify what we're going to talk about in the Resource Center as key specialty providers, or those providers deemed most relevant in order to be able to respond to different components and diagnoses that come from the effects of COVID-19 and the pandemic. We'll look at, outside of that, our de-identified medical claims, which provide clinical insights and help identify things like age and comorbidities. We'll look specifically at diagnosis, treatments, practitioners, facilities, in order to help judge a county-level risk assessment across all U.S. geographies. And we also brought to bear our consumer public record information, which was used to evaluate not just those age and comorbidities, but their correlation to different socioeconomic risk factors, which could represent a high risk and prevent optimal health outcomes if left unaddressed. So as you see each of those assets, some of the different components that we pull tied to public records is that individual and business level information, as well as demographic information and socioeconomic attributes. From de-identified claims, those comorbidities, we also looked at the telemedicine utilization and overall diagnosis and procedures used. And then from a provider standpoint, again, that's looking at the number of providers by location, physicians by specialty, the different facility types, as well as their individual capacities. Now, as part of this risk assessment, LexisNexis choose to just use a national percentile ranking in order to provide a true county-to-county level assessment. All categories that we've talked about so far are kind of scored by county as part of this percentile ranking in order to give you, on a scale of 0, which is low risk, to 100 or high risk, a different percentile ranking. Each of these will have a risk score, so a risk score of 90, for instance, will indicate that it's in the 90th percentile for that risk metric, meaning that among all counties in the country, that county is better off than 10%, while worse off than 90%. As percentile rankings are specific to each risk attribute, we are recommending, as folks leverage this resource, that they consider metrics individually and then also look comparatively across the different categories so that they are able to achieve the most holistic county-level view. As I mentioned, the Data Resource Center is pulling in a wealth of different industry assets, and one of those, and the most important of which I think upfront, is the case-level information. This is coming from partners through Johns Hopkins University. So if there is anyone from Johns Hopkins, this is part of that heat map. You all have been showing that you are industry leaders in being able to capture and show the distribution of that across the industry. So you'll see both confirmed case information as well as deceased information reflected here. And as you look at county by county within the Data Resource Center, we'll be looking at minimum and maximums for any county based on all those national numbers observed. So again, we are using this in order to do that true county-to-county level assessment. So as LexisNexis went to build the COVID-19 Resource Center, there were really two questions that stuck out to our data scientists and industry stakeholders, and those are really which communities are most at risk for poor health outcomes due to COVID-19, and really which communities are most in need of those critical care resources in order to help combat the pandemic. Answering the first question, obviously as COVID has spread throughout the United States, health policy officials, practitioners, hospital systems, and others have really been challenged to identify the potential extent of population impact, as well as the ability to gather intelligence on where they could have the greatest impact to help flatten the curve. We've seen that there's been success in doing this in many parts of our nation, but really in order to do this, it requires a clear understanding of the current at-risk status of that population. Lexis has been working to facilitate this information really in three different categories. We've been looking at age and comorbidities, those age and comorbidities related to socioeconomic risk factors, as well as health risks by age and condition. These, which if left unaddressed, would certainly preclude optimal health outcomes, also give an underlying understanding of what conditions exist within their population and which could be most impacted as it continues to spread. In terms of the community piece of which communities are most at risk, these individuals, the practitioners, the hospital systems are also challenged to identify what the capacity is for the regional healthcare resources. As such, we feel they need a thorough understanding of not just where there are providers with specialty expertise to treat potential COVID-19 patients, but also where there's hospitals that might have capacity to treat patients and how many ICU beds are available to treat patients within each of those regions. As such, this question helps counties kind of throughout the United States address and understand their level of preparedness compared to their peers as they work to meet the potential needs of that high-risk population and really provide a line of sight into opportunities to expand resources. Eventually, this kind of second question also prompted us to look at some of the adoption that has occurred through telehealth, as this is an opportunity for at-risk communities to mitigate some of those critical care gaps through the advent and adoption of more remote-based services. So looking among the vulnerable populations, there's two that I want to spend a moment on, and then there's a third I'd like to highlight. These first two are age and comorbidities, and then specifically looking at a health risk by age and condition. So since early in the pandemic, there have been a number of uniformly reported publications on COVID. We've seen a number of different things contribute to the morbidity and mortality, and as parts of the U.S. population began falling ill, we saw additional correlations to higher underlying conditions that ultimately could put an individual's health in greater jeopardy. As a result, when we looked at high-risk populations, we looked at those who were over 60 years old. We first looked at those that had 2 or more high-risk comorbidities. In this case, high-risk comorbidities include things like asthma, cancer, chronic lung disease. We leveraged CDC as well as a number of industry publications to evaluate which ones we thought would have the greatest bearing for those that were doing resource planning. But then we also looked and went back and added an insight into the health risk by age and condition with a much more specific targeted view. So in that case, we looked at those, again, over 60, but with one significant underlying condition that could impact their overall health outcome. In order to pull this data together, Lexis looked at a repository of the identified medical claims, and this is leveraging about 1.6 billion annual medical claims from across the industry. We pulled this data from different clearinghouses and switches. We have line of sight into practitioners, where they're practicing, which facilities they're a part of, and we're able to leverage that information to also look at diagnosis and procedure level data in order to gain a much better understanding of the individuals that could potentially be at risk within their population. The third high-risk category that we looked at was those with a socioeconomic risk factor. We included the socioeconomic attribute primarily to look at economic stability factors such as housing, financial health, other indicators that, if left untreated, could actually result in a less than optimal health outcome for the population. Much of what we've discussed up to this point is about how population health can be really trained to impact pay for value, but understanding how SDOH factors can also give you kind of an insight into which qualities on those individual levers could impact the clinical quality metrics, gives you a line of sight into which populations could be at significantly more risk. So looking specifically at COVID and then broader within the industry, we've all heard these population stats before, that the top 5% of the population using health services accounts for about 50% of all costs, and the very top 1% alone accounts for 20%. This has led really to an intense effort to coordinate at-risk individual care and to ensure or improve or at least maintain their current health conditions so that individuals don't deteriorate. This is kind of where SDOH can come in and make a huge impact, not only helping us to understand a patient's social and economic situation as a predictor of risk, but also allowing care coordination to know what factors they might want to include in a potential care plan. An instance of this is if you're a diabetic, you might want to have, if you have a population that's diabetic, you might want to have a plan that allows for outreach to occur more frequently. Similarly, if you know that they're socially isolated or living in what is termed as a food desert, you may want to make sure that things like Meals on Wheels can deliver to them and help not exacerbate their condition further. In terms of the resource center's critical care gaps, we looked at provider risk, hospital risk, and ICU risk as three primary indicators of potential gaps. The key specialty providers here, you'll see we've pulled out anesthesiologists, cardiologists, critical care, emergency medicine, hospitalists, other areas that are very focused on treating populations that have come down with COVID-19. You'll also see with hospital risk, we're looking at the number of known beds, and with the ICU risk, we're looking at the number of ICU beds prevalent by county. As we look at each of these, they address different questions in terms of the availability of resources. We then went back and started to look at telehealth trending insights in order to provide a line of sight into where some potential practitioner resource gaps are currently being mitigated through transitions to digital services. As we all know, traditional delivery of services has undergone a pretty significant transformation over the past few months. We've seen a suspension of elective surgeries, temporary closures of offices, and many of these providers have transitioned to using telehealth for remote patient evaluation, diagnosis, and treatment. One of the advantages of this is it's helped our populations really not only maintain continuity of care, but also help support those social distancing requirements while making sure that those at-risk communities are able to benefit and gain access to the vital services and practitioners that are most important for their ongoing treatment and diagnosis. I know as a parent, seeing that advent and adoption in the pediatric space was certainly a relief as those became high-stress interactions. So when we looked at telehealth trends, we chose to look at two different areas. This initial graph shows kind of the overall increase in telehealth over the past calendar year. We looked at, using 2019 as a baseline, the overall increase that we've seen nationally, and then we took a look further and actually broke down and looked at specifically the top specialties that saw the greatest percent increase over that window of time. Looking kind of week by week, we've seen these ebb and flow with new practitioners adopting telehealth for the very first time. But some of the areas that I think are worth indicating is we've seen, for instance, adoption of orthopedic surgery, we've seen pediatrics, we've seen behavioral health. Some of these have gone from hundreds of claims to hundreds of thousands of claims in very short windows of time. So we're going to take a look at this, and now we're going to jump into kind of a live view of our Data Resource Center. So bear with me one quick second while I share my screen. Okay, so we're going to take you through the COVID-19 LexisNexis Resource Center. This is at covid19.lexisnexisrisk.com. As you see the website for the very first time, you'll note that you land at an overarching heat map at the top of the page. This is going to be defaulted to an age and comorbidities level view. We'll populate. You can zoom in and out. This is an interactive map. And as we do that, you'll see over on the right, there's an opportunity to select an attribute. There is a drop-down here. We'll go through this in just a moment. But you also have an opportunity to hover over and see different counties throughout the United States to understand those counties' individual risks for each of the different factors that LexisNexis has pulled together from ours and industry data assets. So we're just going to pick a county, and that will populate then over on the right. You can still hover over other counties. You can do a county-by-county comparison, kind of side-by-side as you might be investigating the impact in a specific region or potential impact. You'll see here it breaks down all of the different categorical risks. Up at the top, you can do this on a drop-down, and as you actually select each of these from a drop-down, you're going to see the map will change. So starting with this age and comorbidities, this again is looking at individuals with that are in the 60-plus range with 2 or more underlying conditions. And we'll talk through those underlying conditions again in just a moment, but you'll see that the heat map is showing that percentile rank distribution according to that. We also chose to layer in socioeconomic attributes as another example. And as we select that, you'll see the map shifts a little bit. This is showing the difference in risk between that, again, age and comorbidities, which we were just on, and the socioeconomic factors. Limited access to different socioeconomic factors, things like financial instability and an ability to get from point A to point B to see a practitioner, limited access to things like food. That can increase a population's risk for optimal health outcomes, especially as they're impacted by COVID. During a pandemic where we have a lot of social distancing, a lot of folks staying at home for long periods of time for the very first time. You'll see here under some of the care capacity risks, there is provider risk, which you can select. This will give that nationwide percentile ranking. It's showing a drop-down within that map of how each county represents compared to their peers for the number of key specialty providers available to treat patients that could come down with COVID. We can talk through those specialty provider types in just a moment. You'll similarly see for hospital risk the availability of hospital beds. If there are gray areas on the map, it may mean that there's not data reporting from those locations. It can also be a source of risk as well if it either doesn't have a hospital within that region or it's just not one that is actively being reported. You'll see ICU risks. This is based on the availability of ICU beds, again, correlated to that high-risk population in the age and comorbidity section. You'll see under health risk, we had a number of questions come in as a result of displaying that age and comorbidities and some of the underlying conditions that put populations at greater risk. So we had questions come in tied to heart disease, diabetes, hypertension, lung disease, and different diagnoses within each of those categories. So if you select each one, you'll see the distribution change based on the prevalence of those individual conditions within the different communities. For this section, just note that you are looking at that 60-plus population with only one underlying condition, and that's specific to each of these individual groupings. We can talk through what's in each of those categories, but with diabetes, it would be looking at type 1 and type 2. Hypertension, there's a variety of different hypertension and high blood pressure type disorders that are captured here. And then at the very bottom, you'll see case information. This is coming from Johns Hopkins data set. You'll see here it has been confirmed as well as deceased information. This updates multiple times a day from that data resource and partnership. So each of these gives you a different view, really, of the overarching risk for your community or potential risk for your community as it relates to others within the United States. So regional planners can use this to look at different subcomponents of their state and geography, understand how they're doing compared to their peers, understand disease spread based on where it's occurring in different epicenters or emerging in different communities. And the goal of this is really back to those two key questions that we talked about before. So which communities are most at risk and which communities are most in need of critical care resources? As you look through that map and interact with it, the at-risk populations from age and comorbidities or potentially at-risk populations are those that have that underlying condition, the socioeconomic or potential risk of not having access to some of those factors, and then specific underlying conditions that have shown to have a high degree of interaction with COVID-19 and potential risk for the patients that have that as a result. Over on the right, that second question, those critical care gaps, we looked at that through provider risk and hospital risk, as well as ICU risk. So that's looking at each of those compared to the high-risk population and the numbers of either key specialty providers, available beds within a hospital or ICU beds within a hospital or region. So that you have an understanding of really where those gaps could occur and where they might be taxed over time. Now, as we were looking at this section specifically, this critical care resource gaps, we were first focused very much on displaying this from the lens of availability of specific resource types, but we recognize that as more and more folks move towards telehealth adoption and practitioners within the industry and hospitals started moving to having patients seen in more of a remote capacity, some of those provider gaps or hospital risks could be addressed as a result of the availability and accessibility of those practitioners in a new way. So this actually is what prompted us to develop the telehealth trends section. You'll see here two different graphical breakouts. The one on the left is the overall percent increase in telehealth claims by week. This is using 2019 as a baseline. So you'll see we saw in terms of telehealth services broadly within the industry as high as over 7,000% increase compared to the previous year. Over on the right, you'll see this breakout by key specialties, and this is really looking at the top weekly increase. You'll see these top 10 will vary really week over week. But what this is allowing you to see is practitioner specialty types that have suddenly adopted telehealth for the first time. Just in the period that we have this launch, I've seen new specialties add and come off of this list as a result of adopting telehealth for the very first time. This is all hover over functionality, so you can look here and see gastroenterology, for instance, saw over 150,000% increase That's a pretty large spike, probably an instance where you're going from just a few hundred claims to suddenly hundreds of thousands of claims for the very first time. Down at the bottom of this, you'll see there's a little arrow, so you can scroll over for each of the different specialty types. You'll see cardiology, anesthesiology, pediatrics, behavioral care, internal medicine. A lot of these have adopted telehealth for the very first time. I know as a patient or a potential patient with a young child at home, having our pediatrician suddenly adopt telehealth was a welcome relief, as we saw a 22,000% increase with that across the industry, as practitioners were starting to see kids in a more remote capacity in a way they haven't before. I know as a parent, it put my mind at ease to suddenly have my practitioner accessible to me without having to put her at potentially exposed risk in an environment where other folks might be ill. You'll see here, again, this graph is going to vary by week. Different notes, both on the telehealth section and the map up above, are included below. This is where you can get some insights on what drove each of those data models. You'll see the Insights Map data model is the top one that comes up. This talks through our percentile ranking, how to interpret that, the high-risk comorbidities that we chose to focus on, key specialty providers. Again, these are using reviews of relevant market literature and guidance from CDC and other industry publications on which practitioner specialties are most in need for treating individuals that might have contracted COVID and have different underlying conditions. You'll see some details on our socioeconomic scoring. You'll see for care capacity risk, what that term means, the different contributing factors, what the gray area in the map might represent. You'll see health risk, the different breakout for each of those specific conditions, including some examples of what was included within each. For heart disease, looking at coronary artery and heart failure, hypertension, a number of different high blood pressure diagnoses, and lung disease, things like asthma, COPD, and emphysema. And then you'll see notes on the telehealth data model. And then over on the right, there are some resources that are available. We'll walk through this in just a moment. But if you do want an opportunity to use this resource, this is available for researchers, policymakers, government officials, analysts. If you have additional questions or if there's things you'd like to see, there's a contact us. We're accessible and available for dialogue. And again, this is kind of a growing resource center. So over the course of the pandemic, we started with a percentile heat map broken up by population risk, care capacity risk, and case information. We've since layered on additional health risk. We've layered on telehealth. There's actually a pharmacy risk piece under discussion right now. So this is definitely an ever-evolving resource and something I'd encourage you to come back to and check out, whether it's a week from now or a couple weeks from now, as this is updated at various frequencies and has a growing list of components within it. That said, I'm going to stop my screen share at this point, and we will go back to the slide deck. And now I'd like to move back and just talk a little bit about some of the different resources that went into creating the COVID-19 Data Resource Center. This really has been an industry collaborative effort. We've been engaged with a number of different partners, from payers and providers to pharma and life science companies, as each of these different stakeholders are working to bring their resources to the table to help impact our community in the greatest positive way possible. This resource center, being an aggregate, leverages information from Johns Hopkins University, where it's pulling from their data set the case and deceased information. That updates on various frequencies. We've seen that case information updating multiple times a day. LexisNexis brought our repository of provider data assets, which again is driving that key specialty providers. We've pulled in our de-identified medical claims asset, MarketView, in order to give some transparency into those specific health risks and comorbidities. We've also pulled in our socioeconomic consumer public record information to help provide some insight into where there's potential risks for population based on non-traditional factors, but those that have been clinically validated within the industry. The American Hospital Association also contributed data for the hospital breakout as well as ICU bed breakout. And all of our resources have been leveraging the CDC, Centers for Disease Control and Prevention, their information not only on underlying conditions, but other clinical information that's coming out as folks continue to be impacted by the virus, and more lessons are learned over time. The last resource I would note is that Elsevier, our partner company and parent company, has launched a novel coronavirus information center, which is kind of a industry-leading asset for additional health and medical research information. So if you are working to address the pandemic within your respective region, I highly recommend reaching out and visiting that site as well, as it has a number of different insights outside of those presented on the LexisNexis Risk Solutions COVID-19 Data Resource Center. With that, I'd like to pause and just ask if there's any questions from the audience.
Thank you, Rick. The insights that you've presented have been fantastic. We do have a couple of questions that I would like to propose to you, if you are ready. The first question that came up is, we're being asked, how did you decide which key providers and comorbidities to use in the model?
Sure. So for each of those, we looked at a review of relevant market literature and clinical guidance to gain insight into which specific practitioners, which comorbidities were most highly affected if they were to also contract COVID and thus be required to treat patients that had those underlying conditions and the COVID diagnosis. We looked from a key specialty provider lens at anesthesiologists, cardiologists, critical care, emergency medicine, some hospitalists, hypertension specialists, internal medicine, a number of different specialties that have shown relevancy as COVID-19 is, while it started as very much more of an upper respiratory infection, has started to show and exhibit symptoms of other impacts to the overarching health system from folks that have contracted it. From a high-risk comorbidities lens, again, looking at not only CDC recommendations, but other clinical and market-relevant literature, we identified that comorbidities such as asthma, cancer, chronic lung disease, coronary artery disease, diabetes, hypertension. There's a number of different comorbidities that we've seen a direct correlation to negative outcomes as a result of contracting COVID in the event that those conditions already existed within that at-risk population. Tied to that, we've actually had a few different outreach efforts that have occurred to us, asking if we could actually dig a little bit deeper into some of those high-risk comorbidities. And that's what drove really that health risk section in the resource center. So with that, we started looking at specific diseases and conditions that were of greatest concern, one of which was heart disease, aging heart disease, for instance. We looked at things like coronary disease, heart failure. When we had questions on diabetes, we started looking at type 1 and type 2. There's a bunch of different blood pressure diagnoses that went into the hypertension assessment. And with things like lung disease, asthma, COPD, emphysema, those chronic lung conditions were ones we chose to focus on. So our hope is in highlighting each of those in the map, we're able to help provide a line of sight to also correlate to those key specialty providers that are available in each of those respective disciplines and specialties.
Perfect. The second question is, why did LexisNexis choose to add telehealth trending insights to the Data Resource Center?
Sure. So over the course of the pandemic, we've definitely seen a bit of an evolution in terms of which insights have been most impactful. Initially, we were concerned with identifying at-risk or high-risk populations and then where there were potential capacity gaps. But as the pandemic continued to progress and we started to see practitioners and hospital systems start to adopt some more of those remote telehealth services, we thought that that was a lens worth sharing to see specifically which disciplines were now suddenly adopting telehealth that never had historically, as well as looking at where telehealth adoption was occurring and what that increase was. Since folks were moving away from a lot of elective surgeries, folks are more reticent to go in to an office with a practitioner for even routine maintenance as a result of potential risk of infection. The adoption of those services has helped address that care capacity risk in some respects, as folks are continuing to receive care and thus in a larger, better, optimal health state than if they were going in full absence of care across the board. I'd also say that tied to kind of the telehealth piece, we looked at not only the overarching increase, but those that had the greatest adoption, because those are areas where there's suddenly a new opportunity for practitioners to not only offer services to their current client population, but to potentially help actually support populations that might be in a more at-risk or heavily impacted area. That technology, again, is something that is kind of new to the industry, and we think there's an opportunity to layer on additional identity assurance, so to speak, through things like knowledge-based authentication, and where you ask a question to validate the identity or a series of questions to validate the identity that you're interacting with, to help keep things more secure given the patient-doctor confidentiality concerns. I will say for telehealth, we have seen with this adoption overall that there is likely going to be continued telehealth beyond this initial window of time. I know a lot of folks that, stopped for like a cup of coffee, for instance, on the way to work. They've started, they've made it at home as they've been home-based for a while, and that becomes less of a need for them. I know for myself, getting into a doctor was always quite challenging between having to take time off work, having to commute to that location, sit in a waiting room. It was often challenging in some cases, from a patient lens, not worth the level of effort for that kind of routine screening. Being able to do that all just literally from my phone with the advantage of having like a scale and a blood pressure machine at home, that means I'm more likely to be engaged with care. And I think we're going to see for at-risk populations specifically, as the pandemic continues and then kind of post that, an increased need for them to be able to have practitioners accessible to them remotely, hopefully increasing the overall baseline of health within the industry.
Thank you. So one final question that we have, and then we'll turn it over to the next presenter. Why did LexisNexis choose to use a national percentile ranking, and how should I interpret these scores?
Sure. So the national percentile ranking was actually an area of a lot of discussion on our COVID response team as we were trying to figure out what made the most sense in terms of representation of the different data and potential risk. Many folks have different versions of a resource center out there in some capacity. I've seen a lot of them that are at more of a state level, and to me a state level is, well, it's impactful to understand what's occurring within kind of those governmental boundaries. It's also less impactful if I'm doing more regional planning or resource distribution type discussions, trying to understand which things should be available in which locations. The state level, given the variety of population distribution within it, as well as the high-risk populations within that, a county level view just seemed to make sense for more of a city and regional planning, especially as public health researchers, policy officials, departments of health start using that resource. They're looking at a much more isolated group. So a direct correlation to close peers and proximities of spread within a single city that might have multiple zip codes. Being able to view kind of that county level gives them a level of granularity that was missing with that state level view, and that gives them a greater opportunity to assess within state where they might need to relocate resources or make additional practitioners available or petition the local community for additional support as different parts of that state geography were impacted more heavily. As folks are using that percentile ranking, just remember that on a scale of 0 to 100, 0 represents low risk, 100 represents high risk. So for instance, if you've got a percentile ranking of 90, you'd be the 90th percentile for that risk metric, meaning that you are better off than 10% of the country, but worse off than 90% of it. That is specific to each risk attribute. So I highly recommend that health officials look at each of those metrics, not only individually, but look across risk categories so that you can get a real holistic county level view for where your county has either sufficient providers or maybe lacking hospital or ICU beds or a high-risk population, specific to even individual health risks within it.
Thank you so much. I appreciate all of your insights, and I'm sure our listeners do too. We will turn this now over to our next presenter. Thank you so much, Rick.
Thank you.
Claire mentioned, my name is Mary Henderson, and I'm an SVP of Product Strategy here at Blue Health Intelligence Company. I'm excited to spend the next 20 to 25 minutes sharing how we are partnering with a range of different stakeholders to use clinical informatics, data science, and analytics to help address COVID-19. Specifically, today we'll be covering some of our descriptive and predictive efforts, some upcoming research studies, and taking a quick look at our currently available reporting capabilities to address employer-specific risks of this pandemic. Okay. For those of you who are unfamiliar with our company, Blue Health Intelligence, or also as we're called, the Health Intelligence Company, became an independent organization a little over 9 years ago. While our roots and many of our partnerships come from the Blue Cross and Blue Shield system, our close relationships and work has long since expanded into many other sectors of the healthcare ecosystem. We are proud to have grown a full set of robust products and services that are being used by employers, professional services organizations, medical device companies, academic institutions, brokers, consultants, etc. The foundation of our success and continued innovation comes from our rich national data repository. In addition to the 200 million unique commercial lives that our information represents, we continue to enrich our data assets. We were recently named a qualified entity by CMS and continue to enrich our information with new social determinants of health and clinical information variables. Okay. There's probably no better way to showcase the richness of the data that our teams get to work with on a daily basis and to simply show you some of the things that we are currently analyzing. Okay. So even though ramped up fairly recently, we are engaging in a broad swath of analytics efforts related to COVID-19. We are all cognizant of the impact the pandemic is having on depressing many aspects of routine and elective healthcare services. We are monitoring those and are particularly interested in measuring the longer-term impact in shifts of site of care and deferred care on population health and quality. We're also researching the relationship between a broad range of social determinants of health variables and risk of adverse outcomes that are related to COVID. An important area to call out is the impact on behavioral health and potential increases in treatment needs for mental health, alcohol, and substance abuse. Our large longitudinal database is ideal for the development of trend models with the ability to compare predictive baseline cost of utilization with the actual in the new post-COVID world. Finally, our WISEN tool allows us to pinpoint geographic variations in risk and prevalence and tie them to all aspects of cost, use, and other population characteristics. The longitudinal nature of our data set gives us the ability to examine trends across a wide variety of different populations. Descriptive analysis analytics are always the rock bed or starting point, and BHI's consulting and data science professionals have been setting up several critical baseline analyses that will help us all better understand the pandemic. Here's an example of a before and after analysis that we have please put back up, Jennifer. Here's an example of a before and after analysis we have undertaken on utilization of emergency room urgent care, two important measures of access. Using a study design that compared a baseline period of 2019 to January 2019 to October 2019 to January 2020, we investigated the trends in these measures. We looked at the proportion of visits and members that were associated with diagnoses related to upper respiratory infection and also suspected recommended COVID-associated codes. It's interesting to note that the proportion of ER visits grew from just over 9% to almost 10.5%, and the portion of urgent care grew at a similar rate. Next slide. All right, next slide. In this slide, we look at this further, comparing the visit counts for emergency rooms and urgent care for the same month from October to January in 2 consecutive years. These visits are again related to upper respiratory infection and potential COVID. What we see is the year-over-year differences grew from 15%, grew quite dramatically between the two time periods. The difference almost doubled. We are digging deeper to fully get an accurate picture of the potential COVID's early impact by developing profiles based on presenting diagnosis, treatment, and social determinants to focus on cases that more closely resemble COVID as opposed to just using associated diagnoses like pneumonia, bronchitis, etc., as we have done here. We'll go to the next slide. CHI has also developed a set of comorbid conditions following the guidance of CDC that are indicators for more severe outcomes if the individual becomes a COVID patient. We have correlated the risk based on these comorbidities to CDC's Social Vulnerability Index and found that geographic areas that score high on social vulnerability also tend to have a higher proportion of at-risk people. Using person's primary care shortage areas, we can see that the proportion of at-risk members is highest in areas with the lowest population-adjusted number of primary care physicians. And we just also status is not limited to younger, working age members with certain chronic and recent acute conditions are also at risk. And this rate can vary greatly by area. Alabama has a very high risk of almost 12%, while Utah's is less than 5%. Right. Okay, we'll go on. Okay. As many have suggested, we are also concerned about the impact that COVID-19 will have beyond the effect. Increases in behavioral and substance abuse issues may be anticipated. The amount of preventive care and elective procedures have been reduced. In order to measure the impact, CHI has built a REMA model which identifies seasonal variations for 5-year trends for each impacted year. The actual prevalence of these services are then compared to the expected prevalence. A confidence range in blue is also displayed to reflect the degree to which the service varies historically. For example, influenza visits are highly variable year to year, but preventive care is not. As we look to the summer, some of the other things we are excited to explore include answering questions like, how might there be changes in care patterns, and what might be the impact on quality measures and detection rates because of things like delays in elective surgeries, or missing routine immunizations, or avoiding the ER use for emergencies, etc. Over the past 18 months, CHI has been honored to work with 6 leading academic institutions to leverage our rich data and analytic assets to contribute more broadly to the body of peer-reviewed literature that helps inform healthcare policy and program development. As you can well imagine, our academic partners are also interested in COVID-19, and therefore we are formatting 2 specific studies that will dig into some interesting questions. In working with Harvard and Rice universities, we are going to explore some of the impacts on employer-based healthcare insurance and risk pools more broadly as employment changes and individuals move in and between different types of coverage. At the same time, we will be looking at some of the longer-term health outcomes questions that are being posed through a partnership with Scripps and the Blue Cross Blue Shield Association. All right. I'm now going to turn to speak about some of our reporting capabilities through our Wizen analytics platform. And if we're able to, we're going to be able to share a live demonstration of some of these capabilities. Okay. All right. The various, so in terms of Wizen, some of the ways that this particular solution works is that it does have a very comprehensive data profile in terms of integrating all health-related data. We use a state-of-the-art, very visual technology and associated data model that's quite powerful. And it does actually allow us to generate very large volumes of both static reports as well as interactive templates in a short time. And we're also able to use our large benchmarking database for benchmarking capabilities here. And so we can gain a lot of insight, through that particular matter by leveraging that data. Right? This is just kind of a schematic of all the different data that we can integrate within the platform. And as you can see, the wide variety of demographic, financial, clinical, and whether it's programmatic data, disability data, behavioral health, providers, et cetera, all can be leveraged into the platform for reporting and analysis. Okay. In terms of the COVID-19, we wanted to quickly get to our customers the ability to really look at the impact of this pandemic within their data. These are some of the things that we have been able to do, and we'll show you more of this in the live demonstration. But we are able to look at those employees or members who would be most at risk for adverse outcomes if they were to contract COVID-19. We're looking at comorbidities and age and other variables. We can dice population very quickly by subscriber or employee status and dependence. And we can look at other variables related to what plan they're in, et cetera. And we can track exposure over time. We can pull together all of the associated cost and utilization and look at the impact of geography and other sociodemographic variables. We also can look at what happens with patients that do or are suspected of contracting it and have other complications that could impact their. And we can also look, of course, investigate some seasonal and other variations. All right, so we'll hopefully be able to show you some of this in the live demonstration. I'm going to be assisted by Penny Monaco, who's a senior analyst and a senior person here at DHR. She will be driving the actual demonstration of our recording for the next few minutes today. And also, I want to thank the many other countless DHI employees who have put a lot of time into making all of these efforts possible as we go forward here. Okay, so it does look like we do have the live screen share working, and we're able to look at visualization. And if you can essentially imagine that this is a look for one employer, and this particular employer has about 22,000 unique members. And one of the things that we do is we look at those members that have no risk for having an adverse outcome from COVID. And then we also, though, look at that portion of the population which is fairly substantial but is at high risk. And we're able to break that into that population by gender, by age, but we'll just maybe look for now at those the ones that are subscribers or are employees in this particular employer population. So we'll go down and just look at the relationship for employee, and we'll pick them. And because, of course, employers, not that they're not concerned about their dependents, but there's also productivity issues that come into play should their employees come down with COVID and then, be debilitated for long periods of time. So we see how the age changes, and we see how the gender does shift a bit, and we can look at this information. And we can also look by age, if we like, or by the males in the population, and also geographically, where these individuals are located. So we can do that as well. And if we want to look at the high risk, we'll just take them real quick. We can filter on them just by clicking that group, and now we can see, obviously, for the high risk employees, the age distribution changes. We're able to look at what counties these folks are more likely to be located in, and we can look again at their gender and age. We do have the ability to drill right into exactly who these individuals are. We're not going to do that in this demo. This, of course, is the identified data, and most of our users are only allowed access to that. Let's go on to the next visualization, where we'll take a look more at the clinical conditions related to this. So here's what we've done in this particular visualization is look again at the member age categories, but then we are stratifying the population based on the number of comorbidities. We have a number of the population that have no comorbidities, about 15,000, but then we have the other distributions here as well, and we even have a number of individuals with over 6 different comorbidities. And down on the right side, we do actually list the different comorbidities that we're looking at here, and that come up. So let's just go ahead and look at those individuals with 6 or more comorbidities, and we can see some interesting things in the data. We see that morbid obesity is one of the top ones that we've got there. We also see diabetes, et cetera. And we can see, for example, if we clicked on diabetes, we could actually determine, where exactly those people were located. But let's also look at people that, again, let's look at the employees just for the heck of it under membership. So we'll choose those same people. And then after that, what we'll do, we'll actually look at how many of these employees. And again, here you can see them. We might even we could even pick ones that are older, depending if we want to pick the older age group there. We could do that maybe, 50 to 64. I'm going off script here a little bit. And so we see who they are. And again, morbid obesity, diabetes, coronary artery disease comes to the top, renal failure. But what would be very interesting is to know how many of these people does the employer already reach out to through any type of the care management or disease management program. So what we're going to do now is actually look at that through that care management indicator flag, and we'll look at the ones that they do reach out to. So let's just click yes and see how many of them they have here, because there's about 20, if I can read that right, about 25. And we can see now that number does drop down to about 15. And but that's showing kind of who that they've got a good way to really reach out and make sure that they're doing the best that they can, that they are getting the service that they need to stay healthy through this time. So you can, and we can in fact again another course what we wanted to here look at people that are not being identified for care management, and then this particular system will in fact generate a list of those people that then can be pushed out to the care management program. Now here's a look at a set of people, unique members that have been either diagnosed with COVID-19. You can see it's the early days in the data still, because this data is actually through March, I believe. The actual code, actually I think for April, the actual code just are really kind of new in the data. But then we've got this possible exposure to COVID-19 as well as exposure to COVID-19 diagnoses, and then we've got all others. So what we can do here is, look, for example, at any of these categories of of individuals to see where they're located geographically, what different comorbidity or complications that they might also have in their claims history, and of course we can look at them by age as well. So why don't we go ahead and just look at those the 10 people that were actually diagnosed with the COVID diagnosis code. And what is quite interesting here is that you can see that there are a number of them, almost half of them actually are fairly young, 20 to 39, there's 4 of them that fall into that category. And what's also quite interesting is we just look at those young ones, those 4, we can actually look at what is their most important or kind of severe underlying condition. And here, severe obesity actually is what characterizes the most prevalent condition that these particular younger COVID patients have. So as you can see, we can get a lot of good information in detail here. Going on, because I think we have just a couple of other visualizations, and it's quite easy in the tool to create these types of dashboards and analytic kinds of paths, through the data. So these are just some examples of the ones that we've put together so far, and we'll be growing out that set. So here we're going to be looking at conditions that that also are respiratory in nature, influenza, pneumonia, acute respiratory, and we can track these certainly by geography. We actually can, of course, get down to member counties in this particular visualization. We can look at a state like California if we want to, and actually see where they seem to have out of the Sacramento area quite a high number of some of these case types. And you can see each of these are profiles on the right there, in terms of which type of case we're talking about. So again, a way of kind of looking at possibly related conditions that might provide some early warning to what might be happening with another, spike in the COVID prevalence. And that really gets us, I think, to our last visualization that really does look at kind of seasonal tracking of these conditions and looking at some of this information kind of over the months. So we can navigate to that, and maybe there we go. And here you can see we take kind of a time series look at this kind of a smooth 7-day average look at COVID, influenza, pneumonia, and acute respiratory. And of course, these particular information can be analyzed, and we can actually do predictions in terms of what the next weeks and months of data or experience would likely show based on this history. So I believe we have come to, I know we're getting to the end of our time as well, but we do have a few minutes here at the end. If we can, we'll maybe navigate back to the slide. And we might have some time to answer some questions.
So, Mary, just a couple of questions from our listening audience, and that is, how flexibly can you set different risk levels for populations? So, obviously, when you're down at the account level, someone asked, what is considered risky for one employer or one industry may be different than for others. So what flexibility exists in being able to establish a risk parameter?
Yeah, that's a great question. And because we actually have all of the data contained in the data set, it's very easy. I mean, we have all factors, codes, procedures, other indicators, obviously demographic indicators. We kind of deliver the database with flagged conditions based on the CDC recommendations for comorbidities that are associated with COVID, for example, or complications that are associated with complications of the disease or treatment. And in fact, then we do create some indices counting those up. But there would be a way that the user could very easily weight those different indicators or different comorbidities in different ways, combine them with things like age or different age ranges, combine them with social determinants of health, and actually create essentially their own index on the fly, because the data is stored at that kind of granular level. So I think it would be easy, because I know that's definitely true, that there would be potentially different thresholds for different groups, to different users.
Great, and then just one last quick question. I know we're right at the top of the hour, but some curiosity around kind of which determinants in the social determinants of health buckets seem to be having the most impact, whether it's, economic status, access to transportation. Are we seeing anything there that is rising to the top in the predictive models that both companies actually are running that might be more determinant of poor outcomes than others?
Well, I think our research is fairly young in that regard, but I do think that, particularly I think the economic indicators seem to be the most, weighty that we've seen, and some of the geographic, I think a questionnaire before it that referenced kind of density. Those kinds of metrics are seemingly coming to the forefront there. But there's a lot more research being done on interactions of those social determinant variables with other clinical or other demographics that we're investigating as well, to really get a much better sense of what might be the most impactful there.
Great, thanks. With that, we'll turn it back to MCOL.
Okay, thanks, Janet. And this is Claire again from MCOL. Before we wrap up, I just want to take a moment to thank our speakers for a terrific presentation. I also wanted to thank the audience for joining us. We hope you found today's session helpful. We will be sending a follow-up email shortly and would love to receive any feedback you wish to share. And in case you have additional questions, feel free to submit those along with your feedback, and we will be sure to forward those to the speakers for response. This now concludes our webinar.